Hello and welcome to AHA Science News. We're at AHA Scientific Sessions here in Anaheim, California. I'm Elliott Antman. I'm a cardiologist at the Brigham and Women's Hospital and a past president of the American Heart Association. I had the distinct pleasure of co-chairing a session today with Dr. Paul Gurbel. Paul, let us know about your new position.
Thanks, Elliott. I'm Paul Gurbel. I'm the Director of Interventional Cardiology and Cardiovascular Research at Inova Heart and Vascular Institute in Fairfax, Virginia. And my faculty appointment is with Hopkins. I'm a professor of medicine at Hopkins and an adjunct professor at Duke.
Wonderful. And I will also say that you're my personal guru for anything that has to do with platelet biology. So Dr. Gurbel and I co-chaired a session. It was Late-Breaking Science session number 5. It was entitled New Insights into the Risks, Benefits, and Costs of Antithrombotic Therapy. And we heard 5 papers that were all analyses from trials that had previously been presented. And these were very interesting analyses that seemed to logically coalesce into a few groups or themes. One of which was the idea of reporting subgroups from clinical trials. And as you know from clinical trial discussions, the most reliable information that we have are the main effects seen in the whole trial population. But it is of interest to look at subgroups to see if there is consistency of effect, to see whether there are individuals who might do particularly well or particularly poorly with the treatments that are being studied. We heard 2 presentations that touched on this. One was from the Redual PCI trial, which looked at patients who have atrial fibrillation and underwent percutaneous coronary intervention, and they received dabigatran or warfarin to see what kind of antithrombotic therapy would be particularly helpful. And the main results of the trial showed that there was less bleeding with dabigatran compared to warfarin as the basic oral anticoagulant. What was particularly interesting here were the 3 subgroups that were presented, which were whether patients got into this trial because they had PCI as a result of treatment for an acute coronary syndrome, or whether they had not had an acute coronary syndrome. That was the first subgroup. And the second was what type of stent was put in, bare metal stent versus a drug-eluting stent, or whether they received ticagrelor or clopidogrel as the P2Y12 inhibitor. And Paul, what we heard was that although there were similar relative risk reductions in bleeding, a lot had to do with the absolute risk that the individuals in the various subgroups had. Those who had a higher risk, baseline risk of events, let's say cardiovascular death, MI, or stroke, even if their relative risk reduction was the same, they had a bigger absolute risk reduction because they started from a higher baseline risk. Any thoughts about that?
Yeah, I think we focus a lot in the results of clinical trials looking on the hazard ratio, and we really do forget about the importance of the absolute benefit, the absolute risk reduction. And I think Mark Lackey really discussed that well, because that really is the bottom line.
Yes, and it's actually the kind of thinking that we're doing more and more as we talk about precision medicine in cardiovascular therapies. The other trial that told us about some subgroup analyses was the POISE-2 trial. This was a trial where 10,000 individuals had been randomized to receive aspirin at the time that they were undergoing non-cardiac surgery or to have the aspirin discontinued. And they did not actually intend to enroll patients who had had a prior PCI, but they reported that actually 470 individuals came into the POISE-2 trial actually having had a prior PCI. And they found that continuing the aspirin in the group who had had a prior PCI was associated with a bigger benefit in terms of prevention of death and myocardial infarction. It was almost entirely driven by a reduction in myocardial infarction. Interestingly, no difference in death and MI in the subgroup who had had prior CAD. Did that surprise you at all?
I was surprised by that, I have to say, and the magnitude of the benefit of aspirin in the PCI group was very high and almost unbelievable. And again, this was an analysis of about 400 or some patients from a very large clinical trial where we see the disconnect between the data from the large clinical trial and then compared to this select subgroup. But we do know that patients who end up with stents in their heart have a vastly different biology from patients who don't. In general, they are prothrombotic. When we profile their hemostasis system, we see that they may have potent thrombin generation. They may have high response to thrombin, high platelet reactivity to adenosine diphosphate. So they have a different biology. But again, the level of the impact of the size of the effect of aspirin on these patients, so many years after a stent implant, was almost more than I could believe.
Yes, in fact, Dr. Gersh, who was the discussant, pointed that out. I think it was 3 to 10 years since the stent had originally been put in. And it's a little hard to say confidently that aspirin would have such a big treatment effect that many years after a stent had put in. So let's, just before we move to the next theme, let's remember that subgroup analyses are often considered to be hypothesis generating, interesting observations, not necessarily the kind of information that we would change our clinical practice in response to, but they're often the kinds of observations that lead to the next clinical trial. And that's always important because there's always good questions that come from a good trial.
And that question was raised to the speaker. Where do we go from here?
Yes.
And I think Dr. Gersh did mention that he does not interrupt aspirin for most of the surgical procedures in his patients who have had percutaneous revascularization. But really, the data to support that is absent.
He raised an interesting point, which is that is the common practice. I practice the same way. You probably do as well.
Sure.
And the question now is, do we actually need a clinical trial? And if so, it would have to be pretty big. Who would fund it? And as we think about this, it would be hard to conceive of a classical clinical trial. But as we were hearing about those points raised during the session, I thought, what a wonderful opportunity in the future for us to use the big data analyses from electronic medical records. Maybe that's a place we could
large
turn.
registry data, large database. When I went to the presentation before our session and saw the work that's being done right now to collect data on hundreds of thousands of patients, millions of patients. So perhaps this will help us in our decision making and would be a lot more cost effective than doing another prospective clinical trial.
Right. Let's turn to the next theme. As you know, there are lots of antiplatelet agents that clinicians commonly use in practice. You've done some of the seminal platelet biology work. And let's remind people how some of these agents are actually converted from the state they are in when the patient swallows the pill to the active form, which does its work on the platelets. So could you explain what CYP2C19 is all about and why that's important here?
Sure. Well, clopidogrel is a thienopyridine, as is prasugrel, and it's beholden to metabolism. It is a prodrug. And the cytochrome that plays a very important role in the genesis of the active metabolite is cytochrome P452C19. And we know that in patients who carry a gene that is a non-functional gene, that those patients have a poor pharmacodynamic response to clopidogrel. Not only do they have a poor pharmacodynamic response to clopidogrel, carriage of that loss of function allele also translates to higher clinical events. So it translates to a poor pharmacodynamic response, it then translates to a poor clinical response. When we think in terms of the trials now that are ongoing where aspirin is being deleted from the regimen in patients getting a stent, raises the concern about what happens, what's the outcome of genetically predicted clopidogrel poor metabolizers that have this loss of function allele who don't get aspirin but instead get a low dose of an anticoagulant as part of their antithrombotic regimen. Is it safe? And that concern has driven regulatory authorities to mandate genotyping in those clinical trials where aspirin is deleted and replaced by another antithrombotic agent that has, up to this point in time, never been tested in a patient who's undergone stenting.
Let's talk a little bit about what we mean by is it safe? Because sometimes people think about is it safe in terms of bleeding, but
Right.
I think you mean something else here.
Yeah, I do, and I perhaps misspoke. I'm talking about efficacy, really, safety in terms of
Preventing ischemic events.
preventing ischemic events, right. So that's the big issue. Are these patients who carry a loss of function allele, who are randomized to something other than aspirin, so they're on they're on clopidogrel, they have a loss of function allele, they don't get aspirin in their randomization scheme, but instead they get an alternative active arm with a low-dose anticoagulant,
Yes.
such as rivaroxaban, are they at increased risk for thrombotic events?
So we heard two reports that dealt with this whole issue of clopidogrel responsiveness, if you like, in terms of their metabolizer status. So the Gemini ACS trial and the Prague 18 dealt with this. Want to give a quick summary of what you heard about those two trials?
Well, in the regulatory authorities mandated genotyping in the Gemini study. In the Gemini study, just to recap that, the design, that was a study that enrolled patients with acute coronary syndrome, and these patients were randomized to aspirin versus rivaroxaban on top of clopidogrel or ticagrelor, and the P2Y12 inhibitors were given at the discretion of the treating physician.
And they were supplied to the investigators to give to the patients.
Supplied to the investigators, exactly. And the amazing thing, there were many amazing things about the genetic study that Magnus Oman presented from the Gemini trial, was that 99% of the patients were genotyped. So they had a very high frequency of genotyping. And then what they did was they gave this genetic information back to the doctors who were taking care of these patients, and they wanted to see whether they acted upon it or not. And the sobering data for me from that trial were that the doctors, in large part, the vast majority, did not act upon the genetic information. Even in the presence of a patient on clopidogrel who carries two loss of function alleles, who the genetics would predict a dismal response to clopidogrel, a significant percentage of those physicians, investigators, still kept the patient on clopidogrel.
Well, how did the patients do?
Well, we never really found out from the presentation how the patients did, because the outcomes in relation to the therapy with respect to the genotype were not presented, but these data, of course, will be analyzed. The paper really just focused mostly on whether what doctors did when they got the genetic information and what the frequency of switching was.
Practice pattern.
Right.
Just so that we're clear on this, from the literature and from your own studies, I know there are ethnic variations in terms of what proportion of people are considered to be these poor responders, and could you just update us on that?
Sure. Well, somewhere between 25 and 30% of Caucasians will carry at least one loss of function allele for CYP2C19. In the African American population, the frequency is slightly higher, maybe around in the low 30s%. And if you're East Asian, as high as 50% plus. And the frequency of carrying two copies, being homozygote for loss of function allele, in Caucasian is around 2%, slightly higher, maybe a digit percent higher for African Americans, and somewhere around 10% or so for East Asians. So there is, and we do know that in those patients who carry two loss of function alleles, they will definitely have a much higher level of platelet reactivity to ADP as compared to the wild type who don't carry a loss of function allele.
So the issue, of course, is what's going to happen to the patients who are known to have these poor metabolizer patterns, genetic patterns, and I'm not sure we're going to see definitive results, because the event rates were pretty low in this trial, and despite the very large concerted effort, there still is a relatively small sample size that we're dealing with here. So they can't really answer this question. So it's still going to be an open one, but it's a fascinating one. Let's talk about Prague 18. The Prague investigators have given us a whole series of trials. We're up to Prague 18 now. Tell us a little bit about that one.
So in the Prague 18 trial, patients were treated with either prasugrel or ticagrelor, and they were followed. It was a study of about 1,200 patients, and they were followed, and the medications were not provided by the investigators. So the patients were treated, and if they could afford to stay on the drug, they stayed on the drug. And the original results of Prague 18 showed really no difference in outcome, but again, it was a study of 1,200 patients, certainly not the size of a study like Triton or Plato. So it raises the question of whether the study was adequately sized to state that there's no difference. But the authors concluded that there was no difference between the two treatment groups. And in the paper that was presented today, there were data on switching, and a high frequency of the patients actually switched from the more potent P2Y12 inhibitor regimen to clopidogrel because of economic reasons. And it turns out that in those patients who had physician-directed changing of the therapy to a lesser potent P2Y12 inhibitor, clopidogrel, those patients did okay. But again, this is non-randomized, and if you looked at the analyses of the patients who stayed on the more potent P2Y12 inhibitor as compared to those who switched over to clopidogrel, these were a sicker group of patients. They had a higher Killip class score. So I think, although the authors concluded that under the direction of the treating physician and for economic reasons, if the treating physician feels it's safe, that these patients in fact actually do well, I think that really is not borne out by the data, and I think it's potentially a dangerous message.
Yeah, and we have to give them credit for trying hard.
Sure.
And this was an academically sponsored trial. It was not industry sponsored. And actually, the Data Safety Monitoring Board stopped this trial for futility because they just concluded it would be very difficult to enroll what their original projection was, were about 2,500 subjects. So they provided some information, but nothing that would be definitive there. Let's close with a discussion of the COMPASS trial, which looked at patients who had stable coronary artery disease, and they were comparing 3 treatment arms: rivaroxaban in a low dose plus aspirin, rivaroxaban in a somewhat higher dose, and aspirin alone, and followed patients for 23 months. And what was seen here is that in this report was that there were fewer events in the individuals who received rivaroxaban plus aspirin than aspirin alone. And that makes sense because we've got some more potent therapy. There was more bleeding, but what they showed was that the combination of rivaroxaban plus aspirin actually reduced events that led to hospitalization, and therefore the hospital-related costs were lower. And then some very interesting economic modeling was done, both by the original presenter, Dr. Lamy, and then by Dr. David Cohn, where they said, well, what would this roll out to mean in clinical practice if we could project what the cost of the pill would be? So let's remind people, this is 2.5 milligrams of rivaroxaban, which is not approved, and it's not approved for this indication in addition. So we don't know what it would cost. So these were a series of interesting modeling exercises. And the idea would be that if you actually knew what the cost of the pill was, and they projected, let's say it was $7 a day for the cost of a low-dose tablet of rivaroxaban, just hypothetically, that would cost about $200 a month, and that would, in some instances, neutralize a bit the reduction in the hospital-related costs because you're spending more for the pill. But just as we talked about subgroups previously, those individuals who had peripheral arterial disease or multiple vascular beds, who therefore had the higher absolute risk, seemed to benefit the most. And actually, David Cohn said if the costs are as he projects it, it would be what he called an economically dominant strategy to actually use rivaroxaban plus aspirin, because those individuals had such a high rate of events that the reduction in the events would so offset the increase in the cost. So what was your reaction to these economic modeling exercises?
So I thought that it was an intriguing presentation and also a great analysis by David Cohen. But on the flip side is the bleeding part and the cost of bleeding. And we know, and that was not analyzed. So I think that's another part of the equation, because we know that when we institute more potent antithrombotic therapy, there's a bleeding hazard to pay. And I think that needs to also be taken into account.
Absolutely. Paul, this was a very interesting session, and it was a pleasure to co-moderate this session with you. Thank you for participating. And I hope that those who are viewing this will take the time to study the results of these trials and the kinds of interesting analyses that we heard here at AHA Scientific Sessions in 2017. Thank you very much for listening.